Welcome to A New You. My name is Eva Siffis. Australia is a global leader in neurological research with numerous institutions and researchers dedicated to understanding, preventing and treating a wide range of brain and nervous system disorders. The research landscape is vibrant, covering everything from fundamental neuroscience to clinical trials and rehabilitation. Brain injury research in Australia is increasingly embracing lived experience and co-design methodologies, meaning people with a brain injury are not just research subjects, but active participants and even leaders in the research process. This ensures that research is relevant, meaningful, and addresses the real-world needs of individuals.
I find it quite inspiring to work with people who often their life has changed in a moment. And people work so hard to build a good life and to understand themselves, and I see that as a really optimistic trajectory of things are going to get better. And so that really compels me to help people with brain injury. And then to work specifically with challenging behaviour, and particularly this approach. My mentor, my hero is Tim Feeney, who's an American
I've heard of that name.
Therapist, and he's with his mentor, who was Mark Ilvasaka, had really led the field in our world of working in this way, in this really person-driven, humanist way. And he's a very inspiring, hard-working, innovative clinician, and I've learnt from him, and our research was to take this model of this way of working and do some research to kind of help get the evidence for, is this actually improving people's outcomes?
Connectivity Traumatic Brain Injury Australia has an active lived experience advisory group. This group is made up of individuals who have experienced various types of brain injury, from concussion to more severe traumatic brain injuries, and their carers. They provide invaluable guidance on connectivity's education, information and research initiatives. They help identify gaps in information, advise on effective ways to communicate with traumatic brain injury survivors, and are often offered opportunities to participate in research projects across Australia, helping to shape and improve future outcomes. Medical Research Future Fund, an Australian government initiative, funds many of the major research projects, actively seeks feedback from the community and people with lived experience when developing its roadmap and implementation plan. This ensures that the research priorities align with what matters most to those affected by brain injury. Co-design involves working collaboratively with people with lived experience throughout the entire research process, from identifying research questions to designing interventions and disseminating findings. Australian Traumatic Brain Injury Initiative is a major national consortium focused on predicting outcomes from moderate to severe traumatic brain injury, and they have explicitly involved people with lived experience. They consult extensively with people who have lived experiences, including an Aboriginal and Torres Strait Islander advisory group, to develop their single data dictionary of predictive markers. This ensures the data collected is relevant and that the collection methods are culturally sensitive and appropriate. This direct input aims to improve personalised care. Concussion discharge communication strategies is a mixed method study which employed a stepped co-design method to engage parents and youths who have experienced concussion and clinicians. They worked together to develop improved discharge communication strategies for adolescents presenting to emergency departments with mild to moderate head injuries. This direct input led to prototypes for clearer information on what to expect after a head injury and concussion discharge. Various institutions, including Monash University, have pathways to open employment for people with acquired brain injury. This research specifically used a co-design approach with people who have lived experience of acquired brain injury to review existing vocational pathways. They aimed to identify enablers and barriers to open employment and considered features for effective employment support, leading to the development of a new pathway called Employment CoLab. Some organisations like Brain Injury Matters in Victoria, a self-advocacy organisation run by and for people with acquired brain injury, are very focused on empowering people with brain injury to take on leadership and advocacy roles, which can include informal or formal involvement in research projects. While less common for pure lab research, Their lived experience is invaluable in shaping qualitative studies, understanding barriers to participation, and interpreting findings.
I actually think that that's one of the most important and valuable ways for us to help people to expand our research to make sure it's authentic. There's a term called co-design, which has become more and more mainstream. And at the research centre I work at, the Monash Epworth Rehabilitation Research Centre, I lead the co-design and community translation work there. And so that's a big part of my work. So for example, I do another topic around cyber safety, and someone who was from my clinical practice, Colin, he unfortunately experienced a romance scam, and there wasn't research and there wasn't resources available of how to help Colin. So Colin and I, for the last 10 years, have been leading work to develop the evidence and support services, and we have now a brand new therapy program where we help people who are struggling with being scammed and the aftermath of that, and those are group therapy sessions that are co-facilitated by people with lived experience.
Wonderful.
So they're called Scambassadors.
Oh wow.
and it's a peer group, and it's been really powerful to see how the generosity and the care and the skill in people supporting each other.
The concept of peer support itself, where individuals with lived experience support others, often forms a basis for intervention research. Researchers may study the effectiveness of peer-led programs, with the peer supporters themselves being individuals with an injury. The trend in Australian brain injury research is clearly moving towards greater consumer involvement, co-design, and lived experience leadership. This shift is crucial for ensuring that research efforts are not only scientifically rigorous, but also deeply relevant, impactful, and directly beneficial to the lives of people living with a brain injury and their families. Australian researchers are at the forefront of understanding, preventing, and treating neurological conditions. Their work spans a broad spectrum of approaches and diseases. A major focus is neurodegeneration, which encompasses debilitating conditions like Alzheimer's disease and various dementias, Parkinson's disease, motor neuron disease, Huntington's disease, and progressive supranuclear palsy. Here, research aims to unravel how these diseases progress, discover early diagnostic markers, and develop revolutionary new therapies. Significant effort is also dedicated to mental health. Australian scientists are delving into the neurological foundations of conditions such as schizophrenia, bipolar disorder, depression, and anxiety. This often involves exploring the intricate circuitry of the brain, understanding genetic influences, and pioneering novel treatments, including advanced brain stimulation techniques. Then there's translational neuroscience. This vital area focuses on bringing laboratory breakthroughs into real-world clinical solutions. It includes important work on preventing falls and improving balance, addressing chronic pain and injury, and advanced brain mapping. For epilepsy, researchers are committed to improving diagnostic accuracy, developing new treatment options, including minimally invasive surgery, and identifying the genetic roots of the condition. In multiple sclerosis, or MS, studies are underway to understand disease progression, explore groundbreaking new treatments like stem cell therapies and highly effective medications, and even use mobile technology for ongoing patient monitoring. Stroke research is focused on enhancing rehabilitation outcomes, understanding how the brain repairs itself after an injury, and developing crucial new interventions. And importantly, institutions like the Murdoch Children's Research Institute are dedicated to childhood neurological disorders. Their work aims to improve the lives of children with conditions such as cerebral palsy, severe childhood epilepsy, and rare genetic neurological disorders like leukodystrophies. There has been a lot of research into mild brain injury, referred to as concussion, particularly in sport.
for the majority of people that have a mild traumatic brain injury, or otherwise can be referred to as a concussion, they do recover within the first month, so sort of 2 to 4 weeks after their injury, they're back to their normal activities. However, we know that around 30% of people, sometimes some studies quoting up to 50%, these people do have a delayed recovery, and that can be a number of debilitating symptoms that continue for months or even years after an injury. And as you say, just because the word is mild, it doesn't mean that those symptoms are mild, and the hard part is they're often invisible as well, so it's not as obvious that these people might be experiencing a number of challenges. But what our research is trying to do is to better understand the people that recover or have that delayed recovery period. So there's ones who are the predictors of people who are more likely to have a prolonged or delayed recovery, and how we can better understand that to improve recovery, but also get more timely and specific help in those early stages to reduce the chances of those persistent symptoms.
So tell me about the work that you're doing internationally. What sort of projects are you
Our current focus is really about the AusMTBR study is really about Australia looking to expand that into different countries in the future, but for now what we're looking to do is use an app to better understand predictors of outcome, and so collecting information from people who have had a concussion, and it's for all sorts of concussions. So concussion obviously is common in sports, but it can be from things like falls or violence and car accidents, things like that as well. And so trying to understand those people who are more likely to have a delayed recovery, and using the app. So with the Head Check app is the app, and then our project is sort of an arm, a branch within that. And using that, it's got an inbuilt recovery program, so it offers not only the research, but it actually offers people a graded recovery program to help with their recovery journey. And then it sort of monitors your symptoms as well. So we're asking about your symptoms at different time points after your injury, and giving you that information in a real-time sort of personalised sense to help you continue to get back to your normal activities. So covers things like normal physical activity, so going for a walk or playing sport, as well as returning to study or returning to work. Been developed with the concussion guidelines that have come out, and it's all evidence-based and very thoroughly sort of checked. There's the actual app itself has been around for a number of years, but this is the first time it's been sort of revamped to include a research pathway.
Monash University is a significant hub for research into sexual function after brain injury, particularly traumatic brain injury. Researchers such as Professor Jenny Ponsford have extensively documented the prevalence and types of sexual changes experienced after traumatic brain injury. Examples of their work have shown approximately 36 to 54% of individuals with traumatic brain injury report difficulties with sexuality.
Over many years, Eva, we've been following up people like you who've been through the hospital, who've sustained traumatic brain injury, and asking them about their sexuality, and find that the majority tell us that they experienced negative changes in sexuality, not only that decline in sexual function, but also their sexual well-being, their self-esteem, their body image, their confidence in relationships. And so having done that, we felt it was very important to start addressing this issue from a number of perspectives.
That's really exciting. So it seems like a great hurdle, a great part of the difficulty was actually broaching it with the actual clinicians. So
a lot of it was, role playing with them. They just felt so nervous about saying the sex word. But that said, although we've achieved it for the time being, we feel that ongoing training and support is going to be needed to sustain that change, because there is still this lingering discomfort. The neuropsychologists have stepped up, and they've agreed that they're going to routinely raise sexuality as part of their history taking and discussions with their patients, and we're just hoping that can go forward. But it's going to need to be built into staff education programs to be able to continue it on, and they need a lot of practice. And then the other issue, of course, that they raise is that when patients say that they have a problem, they want to know what to do about it. So the third component,
who wants to do
well,
about it?
so the staff the clinicians say, well, we're not experts in sex therapy, what do we do? So to that end, we have also, and this was Eleanor Fraser did this as part of her doctoral research, developed a cognitive behaviour therapy intervention that is being evaluated in an ongoing way at Epworth. And that is therapy. It's got 12 different modules. It's very individualised, but it's designed to assess what is important for that particular person, and it might be just a person by themselves or a couple who is undertaking the therapy. Everything from undertaking psychosexual exercises, but also working on communication and self-esteem, self-confidence, all these different components, and we use whichever modules are appropriate.
Monash University, through the Monash Epworth Rehabilitation Research Centre, actively recruits participants for ongoing studies. One of their current research studies, directly related to this topic, is cognitive behaviour therapy for sexuality disturbance after traumatic brain injury. This study aims to evaluate the effectiveness of a holistic CBT program. Eligibility typically includes a history of traumatic brain injury, sexuality difficulties resulting from the traumatic brain injury, and being aged between 18 to 65. There have been other developments in Australia, such as the HiMAT, which is a high-level mobility assessment tool. Unlike many standard mobility assessments that focus on basic functions like walking or getting out of a chair, the HiMAT is designed to assess more complex and demanding mobility tasks, particularly those who have experienced a traumatic brain injury. Professor Gavin Williams led the team that developed the system.
In the majority of cases, we have to demonstrate that our treatments are effective. If someone's not improving, usually the funding for their treatment stops. And if someone continues to improve, then we can continue to get funding to treat that person. So the positive side of that is that if you had an injury, accident, something 3-5 years ago, and you're experiencing a problem, we can still obtain funding to help that person, which is great. So it's not, even if they're in the more chronic phase, it's not just about that early phase. But to evaluate whether the treatments work or not, which is a key thing, everyone wants to know that they're doing the best for their patient, you have to be able to evaluate it. So we have, and this has been a big part of what we've done, is outcome measures that look at that really early phase where people, can they roll over, can they sit up, can they stand, can they get out of bed themselves, can they walk, right? So there's lots of different outcome measures that do that. So we can demonstrate it very easily if we're effective at doing that in that early phase. But once someone sort of gets out of hospital and they can walk, things like getting around the shops themselves, being able to look after their kids, getting back to social, leisure, sporting activities, employment, because many roles involve being pretty physically active. We had nothing that measured recovery beyond walking, and so obviously walking is fundamental. It's very, very important. But there's a big imagine for anyone watching your life, if you couldn't run and the best thing you could do is just walk, it means your walking is pretty poor. It means you're walking slow. You can't keep up, walking down the street with your friends. You're probably, maybe not housebound, but you probably can't walk around the shops particularly well. So this high level stuff is very important for day-to-day life for most people. And so, that's where our gap was, not just in what the best treatments were, but how do we best measure it? And we didn't have a measure. So part of the evolution in care over the last 20 odd years is not just the treatments, but the outcome measures to demonstrate that the treatment's effective. So, we had this running group and we were teaching people to run, and it was all really cool, but we couldn't demonstrate that we're being effective, even though you could see videos before and after. They're not outcome measures. So we had to develop an outcome measure to show that the program was effective. So that was a big driver.
Can you give an example of an outcome measure?
Well, I can give you my own, which is best thing since sliced bread. So so we had a gap, that all these measures were suitable for the hospital, but once someone was out, so we developed the HiMAT, the high level mobility assessment tool. So it basically starts where other outcome measures finish. So, can you stand, get out of bed, walk? So that's where they stop, and that's where we started walking, running, skipping, hopping, jumping, stuff like that. So, it's called the HiMAT, and it was cool because I just started to develop that because we had a problem that we had to demonstrate were effective, and as a result, it's used all over the world. It's been translated in all these languages. It's been pretty cool, but that was never my intention. It was just really to help our program at Epworth.
Well, look at you go, changing people's lives all across the world. That's amazing, Gavin. Well done to you. Wow. Since I was in hospital, it seems like physiotherapy has done like warp speed in a way. Where can you see further improvement?
I think there's massive scope. So, you think about cancer, there's all these, immunotherapy started up and these very tailored programs for different types of cancers and stuff. And in healthcare, the healthcare dollar keeps retracting, and so we tend to have some, generic exercise programs, and they're probably not tailored enough. And so, particularly with Chris's guidance, we're developing programs that are really, for our patients with neurological conditions, very tailored exercise programs, basically like what you do if you're, involved in sport. You'd be your strength training program and other exercises are very specific to the sport because it's all about performance. Same thing with our patients. They want to be able to dance or run or play tennis or whatever, and so we teach them how to run, and we teach them the agility skills, and then maybe the sport specific skills. So there's massive scope to in that field, because historically all the treatments have been about, not to be rude about it, but get them up, get them going, get them out. Mm-hmm. That's what hospital-based rehab's about. Get them up, get them going, get them out. And so the people live in the community with this residual disability, it doesn't mean they necessarily got the skills to interact in that community. So that's one big thing. And the other thing, I suppose, in neurological rehab is that, if you don't have evidence in your field, you might look to related fields. And one of the things about brain injury is that despite some pretty horrific injuries, once people survive, they're typically young and fit. They're healthy, but they might have had, significant injuries. But if you compare that to stroke, a lot of people with stroke have cardiovascular disease and all these other, chronic conditions. And so with stroke, you've got to be careful because of cardiovascular disease if you're going to work someone a bit harder. We don't typically need to worry about that with brain injury. We can really get stuck into them because they don't have those systemic problems. So we can't necessarily look to stroke or cerebral palsy or these other big neurological populations for guidance because they're elderly or degenerative or have got lots of comorbidities. It's typically, the young people with traumatic brain injury where I think we can best, push the boundaries and work out what's most effective.
You can use young people with brain injuries as your guinea pigs, and they'd be very willing to be so.
Yeah, so we published a big study a couple of years ago looking at all the strength training exercise we're talking about, and it's the most effective intervention for people with brain injury, and some of my colleagues have been doing it in stroke, pediatric cerebral palsy, adult cerebral palsy. Someone else is doing it in MS. So what you do may well translate into other fields, and we need to test that. But I think people with brain injury, it's a really good starting place.
Thanks for being with us, Gavin.
Oh, you're welcome. Thanks very much for having me.
That's all for now. If you want to get in touch with us, send us an email. See you next time.